relevant clinical and pathophysiological aspects. I've tried to keep it as practice focused as possible, but I've also covered theoretical elements of the disease as well. My disclosures: I have received honorary from Organon. So I'll start off by outlining the learning objectives of tonight. This is what I hope to accomplish by the end of the evening. So the goal is to recognize the clinical features to support detection and diagnosis of inflammatory bowel disease. The idea is to apply current referral criteria to appropriately identify as well as manage patients who have either suspected or known IBD. We're going to discuss how to select and interpret appropriate initial investigations for suspected disease. I will incorporate recent updates in the management into clinical decision making, and I'll also discuss in detail the non-gastrointestinal symptoms of IBD. Of course, we all know, everyone knows about the pain, the diarrhea. What's probably less appreciated is the non-GI aspects, which we'll cover in detail. So just as a general overview, UC and Crohn's are essentially best classified as chronic inflammatory bowel conditions. They're both broadly similar in that they cause digestive disorders by way of causing gastrointestinal inflammation. So they're incurable lifelong diseases. They typically come on early in life and they by definition are incurable. So unlike celiac, which goes of course into remission with gluten-free diet, there is unfortunately no cure for these conditions. As with other autoimmune diseases, by nature they're relapsing and remitting in the disease courses. This is commonly seen as whereby there's a peak incidence in adolescence and early adulthood. For that reason, it's very economically and socially devastating. This is the age where people are the most productive. They're embarking on study or getting into establishing their careers and their personal lives. I contrast this with people who have rheumatoid. If someone has rheumatoid when they're 65, by that stage they're probably already retired. They probably already had a family. At that stage it would not have the same. So I don't mean to downplay the impact, but it would not impair their working life the way this disease would. The exact cause remains unknown. There's been, as you can imagine, extensive investigations on the underlying cause. It's probably best described as a multifactorial disease process. Some people have tried to argue it's bacterial. It's probably not as simplistic as that. So the factors that play a role are the geographic location, diet, genetics, and immune response. So in terms of the geographic location, this depends on whether you're born in a high or low incidence country, but that is dynamic. It does change over time. So someone born in, say, Kenya will probably never develop, say, multiple sclerosis or rheumatoid arthritis. If they were to move to a developed country, say to Europe, by the time they get to the second or third generation, they've taken up local lifestyles, local diets. They will no longer be having the traditional diet anymore. And by the time they get to the third generation, the disease incidence has reached that of the native population. It's really no different at all by that stage. So these things are dynamic. Diet plays a very key role. The modern diet, as you can imagine, is vastly different to what nature intended us to have. And as a general rule, as people start to have more processed foods, more animal-based foods, the diseases do change as a result. Genetics plays a fairly critical role. Probably around about 10% of patients with IBD have an affected family relative. There's genetic clustering as well described. There's an increased incidence in Jewish populations. It's really related to gene clusters. Having said that, the vast majority of IBD patients don't have an affected relative, but just that the incidence is quite dramatically increased. Now, of course, the key factor is the interaction between genetic and environmental factors. That's what triggers and drives the immune response. So both UC and Crohn's will have abdominal pain, they'll have diarrhea, they'll often lose weight and have bleeding. So as one would expect, it's essentially, it could be regarded to some extent as a disease of affluence and seen in developed countries. So the highest incidence, not surprisingly, is in Europe and North America, as well as, of course, Australia. However, the incidence is rising worldwide. It's becoming increasingly common throughout Asia and Africa. Just to give you an example, in India, patients having terminal artery ulceration, traditionally they usually were thought to have tuberculosis. There's now increasing incidence of Crohn's. So essentially that's related to rising living standards and improved sanitation. They now have more autoimmune diseases. So essentially it's related to hygiene standards. So the trade-off is that we've been on the planet for 2 million years. For most of that time, humans have died traditionally die of infectious illnesses. Now what's happened is there's now been a substantial reduction in infant mortality. So we've had a trade-off whereby we no longer succumb to infectious illnesses. We are now trading that for autoimmune diseases later on in life. Hygiene standards play a key role. So I think there was a study in Britain which found that the number of siblings you had inversely correlated with the rate of having hay fever and asthma. So children growing up with multiple siblings, say a child with 5 or 6 siblings would grow up, you would think, in an environment which is perhaps not as clean, because they have more infections or they have less autoimmune disease, whereas children who are only children would have a higher rate. So essentially there's a fairly complex disease etiology. Autonomic dysfunction plays a key role, bearing in mind the gastrointestinal tract is innervated predominantly by the vagus nerve, which is related to psychological stress. Psychological anxiety and distress in terms of anxiety, depression, I'll discuss that very shortly. You would have heard about the hygiene hypothesis, whereby because the immune system is no longer fighting germs, viruses, or parasites or fungi anymore, it's now sitting out, hence it starts attacking itself. That's the theory behind the hygiene hypothesis. There's also what's called a gut microbiome dysbiosis theory, which I'll elaborate on in a second. And of course, immune modulation plays a role in terms of how the immune system responds to the stimuli. The incidence is unfortunately rising globally. I think the affected rates, the incidence rates, the prevalence rates rather, are out of every 100,000 people in developed countries, there'll be 360 affected people. The incidence is rising, both Crohn's and UC is rising. Australia has one of the highest rates of IBD in the world. So I think it affects something like 75,000 Australians, and notably there's almost 1,600 cases that are newly diagnosed every year. So because the peak incidence is 15 to 35, there's a very big economic impact in terms of time off work, inability to work, and impact on capacity to perform activities of daily living. So in terms of the symptoms, look, they're both quite different diseases. So UC will usually just affect the innermost part of the colon, in other words, the mucosa only, whereas Crohn's is pancolic, it goes right through all layers of the bowel. So the rectum is virtually always involved in UC, and there can be different degrees of proximal extension. So they can range from having just isolated proctitis by itself, which is just the rectum. They can have proctosigmoiditis, whereby it extends into the sigmoid colon. They can have left-sided disease, which reaches up to around about the splenic flexure. There's then extensive colitis, which reaches around about the distal transverse or ascending, or there's pancolitis, which is all the way through. So it should be more severe left than right. As one advances proximally, the disease gets less and less severe. Crohn's, however, can affect any part of the GI tract from the mouth to the anus, but it's usually the distal small intestine and colon. Having said that, upper GI Crohn's is fairly rare. I've only seen my entire career about 4 cases. It's very, very uncommon. It's one of those things that are talked about in textbooks but virtually never seen in clinical practice. So isolated upper GI Crohn's, I've yet to see the date. It's fairly uncommon. Now, Crohn's is quite different to UC in that there's a discontinuous pattern whereby there'll be a disease segment followed by a normal area. That's a so-called skip lesion. So they each have quite distinctive patterns, and because the inflammation is transmural, in other words, it's going all the way through the bowel wall, they end up forming fistulas as a result, or you can have sinus communications to other organs. So you can have fistulas going into other parts of the bowel, to the skin. It could be even to the ureter. So that can present, or it can even be to the vaginal bladder. So they can have, say, pneumaturia, which is gas in the bladder. They may pass fecal matter from the vagina, which means there's a urinary vaginal fistula. So it can literally fistulize anywhere. Now, from a histological perspective, there's the mucosa, the submucosa is thickened, and because it's transmural, there's fissuring, ulceration, and a key component is gronulomas. So because the inflammation is limited to the mucosa and submucosa, they'll end up having cryptitis as well as crypt abscesses. They'll all commonly have diarrhea, rectal bleeding, and pain. Now, the symptoms here are mainly due to intestinal damage. So that can lead to various sequelae, including anemia, and malnutrition. I should mention anemia and malnutrition are more commonly seen in Crohn's than UC because of the small intestinal involvement. So remember, the large bowel does not carry out nutrient absorption. Large bowel only absorbs water as well as a small amount of short-chain fatty acids. Whereas if they have extensive small bowel disease, one would expect a degree of malabsorption as a result. With Crohn's, they can have bowel obstruction if it causes significant bowel inflammation. They can have fistula form. They can have there's increased incidence of infections. Now that's related to not just the disease, but also the immunosuppressive therapy they're prescribed to treat the disease can induce immunosuppression. Having said that, I tend not to see too many opportunistic infections in such patients. Even the ones on high-dose steroids, it's really not that common at all. Again, one of those things you read about in textbooks but don't really see in much clinical practice. There's an increased risk of colon cancer, which I'll discuss in more detail down the track. So this slide shows the differing features. Now, UC has a lot more bleeding than what you do in Crohn's. So anyone having suspected UC, if they don't have bleeding, they probably don't have UC. So that would pretty much rule it out. You would expect, even with limited proctitis, they should have fairly frequent bleeding. So whereas with Crohn's, they would only have bleeding if it was involving the distal colon. If someone had isolated small bowel Crohn's disease, terminal ileitis, you wouldn't expect any bleeding at all. Abdominal pain is more of a feature of Crohn's than it is of UC. Look, it's variable for different people. Typically, it's a mid-abdominal pain described as a cramping sensation. It can be quite severe on occasion because of extensive bowel involvement. Patients with UC don't have pain as much. For them, it's more pretty much a left-sided disease. If they have pancreatitis, it might be mid-abdomen, but usually not quite as bad. Crohn's patients not infrequently have low-grade fevers reflecting immune system activation, whereas this is usually not seen in UC. Mucus is a feature of UC, but having said that, mucus is also seen in irritable bowel syndrome, as we all know. So it's really not unfortunately a very good discriminating feature. Intestinal obstruction should usually only occur in Crohn's. It cannot occur in UC because it's not going because of the pathophysiology. Remember, because it goes all the way through the bowel wall. It can cause obstruction, whereas that should never happen in UC. Perineal disease is pretty well diagnostic of Crohn's. It should virtually never happen in UC. Perineal Crohn's can occur. Maybe you can have perineal disease by itself, where there's where they can have perineal abscesses, fistulas, but no chronic disease. Post-operative occurrence can occur in Crohn's. It usually doesn't occur in UC. So UC. Remember I said earlier it can't be cured. There is a way to cure it. If someone has a total colectomy with an ileostomy inflammation, then that is by definition a cure. Of course, the price they pay is they'll permanently have soft stools because they've lost the colon. With the Crohn's, surgery doesn't cure because if you just resect one part of the bowel, it just recurs somewhere else. Hence, for that reason, it's not usually pursued in that case. In terms of the serology, that's again different. Anti-neutrophil cytoplasmic antibodies commonly seen in UC, not usually seen, whereas we have ASCA in Crohn's. In terms of the features, so UC is virtually always distal colon, rectum. Crohn's could pretty well be anywhere. The involvement is discontinuous versus continuous. The ulceration in terms of the depth is deep in Crohn's, usually quite superficial in UC, so that can be picked up on colonoscopic detection. fish slicing disease is only ever Crohn's, cannot be UC. And commonly Crohn's patients have what's called a so-called cobblestone appearance. So this is like a mirage. What it is, the bowel wall is inflamed, it swells up, it looks like almost like a cobblestone path. It just reflects mucosal swelling and inflammation. The mucosa is not particularly friable in Crohn's, whereas it can be very friable in UC, because remember it's involving just the mucosa. In terms of histological features, so Crohn's patients will frequently have granulomas where it's not usually seen in UC. Remember, this is a non-casein granuloma as compared to the casein granuloma seen in tuberculosis. This used to commonly come up in medical school MCQs. I remember back in the day they used to have a slide and this used to come up in exams. Crypt abscesses is seen in UC, and there's also patchy disease in Crohn's, whereas in UC it's usually fairly uniform. This is a slide of a non-casein granuloma, so that's what it looks like. So in terms of the pathogenesis, genetic pathways are predominantly responsible for maintaining homeostasis, and the key thing is what's called epithelial barrier function. So similar to intact skin being a very good defense against infection, as the same thing applies for the gastrointestinal tract. If there's an intact epithelial barrier, that should be a very strong defense against any disease. What happens is the increased intestinal permeability, it becomes porous and permeable. That allows microbes to invade and cross the barrier. That triggers, now the bacteria by themselves are not damaging. What's damaging is the immune response that they trigger. Similar to, you know in hepatitis B where the hepatitis B virus doesn't cause damage, it's the immune response to it. It's a similar process here. The immune system recognizes the bacteria as being foreign, it attacks it and causes an inflammatory response. So this may initially start off as a self-limiting response to what could be perceived as a temporary infection. However, it does not switch off, it just goes on and on, becomes eventually maladaptive. So essentially what's happening is, remember, the human host is normally meant to regard gut flora as being symbiotic. Symbiotic is meant to ignore them and not attack them, whereas what it now starts to regard them as being foreign now. So there's the symbiosis, the symbiotic relationship has now been lost. In terms of the gut microbial factors now, remember, it's essentially the microbiota is thought to be a very crucial role in IBD. So back when I was in medical school in the early 90s, there was a lot of interest in using antibiotics, particularly for Crohn's. We used to get ciprofloxacin, metronidazole, Augmentin. The trouble was it was only a short-term response at best. You couldn't use it for more than 3 months, and they almost all got drug resistance. So essentially, microbes do play a role, but it's not the be-all, end-all of it. So the GI tract has a very wide range of microorganisms. It's predominantly Bacteroides, Actinobacteria, and Firmicutes. So this is of course influenced by the diet one eats. So people having a diet high in animal-based proteins or processed foods will have quite different gut flora to someone having a plant-based diet. So having said that, I'm not trying to advocate for vegetarianism. I've seen a lot of vegetarians, I've seen even vegans with Crohn's and UC as well. But I'm just saying it's perhaps some scientists have argued it's not so much the meat itself, it's perhaps the hormones, the probiotics that have gone into the meat production that have possibly responsible. So essentially the microbiota is meant to normally coexist with the host bacteria. It's meant to lead to immune response. Ideally they should prevent the gut from being colonized with bacteria that drive the immune response. So ideally they should protect us from enteric pathogenic infections. So essentially innate immunity is where the body recognizes commensal microorganisms, and that as a result of homeostasis there's no gut injury. Having said that, it's hard to nail down a specific causative factor because it's a fairly complex disease, but it's thought that Mycobacterium avium and E. coli as well as C. difficile are high in patients with IBD, whereas they have low levels of bifidobacterium and also increased levels of enterobacteria. So it's thought that breast milk can be protective against IBD because it promotes the host immune response. So you would have heard how patients who have IBS, if you have an acute episode of gastroenteritis, it can sensitize the immune system and make you more prone to getting IBS, hence the concept of post-infectious IBS. A similar process happens in IBD, whereby if they have an episode of infectious diarrhea, that can sometimes trigger off and drive IBD. That's thought that if you have frequent episodes of diarrhea in early life, that can increase the later risk of IBD. So in terms of environmental factors, high levels of fruit and vegetables are thought to be associated with low risk of IBD. Besides meat, high consumption of processed foods, artificial additives and fat and sugar play a role. Now, smoking is quite interesting in that it worsens Crohn's disease but is protective against UC. But having said that, because of the damaging effects of smoking, one would never recommend that someone smoke to prevent UC. So how it works, it affects both the cellular as well as the humoral immune response. It tends to also promote mucus production. Now, smokers and Crohn's will tend to have usually more severe disease. They're more likely to require biologic therapy. They're more likely to need other immune suppressants. They're more likely to progress to surgery. If they do ever come to surgery, they're more likely to have disease recurrence post-surgery. Whereas when UC, it tends to be protective, whereby if they quit smoking, they can have disease flares. And smokers tend to have a relatively milder disease. It's been found that appendectomy can be a risk factor for Crohn's, but protective UC. Now, how that works is that can be confounded by the fact that a lot of patients who had appendectomies may have in fact had right-sided Crohn's disease, and may just have had appendicitis as a first presentation of Crohn's, hence they later present to have Crohn's afterwards. How it's thought to be protective UC is it may act as a reservoir for infection of this chronic appendicitis and hence drive an immune response. So in terms of psychological factors is a very controversial topic as to whether or not that actually promotes Crohn's or UC or not. So I've seen several medical legal cases and even cases in clinical practice whereby patients who have gone through psychological stress or anxiety or poor mental health will then claim that that's caused them to either develop IBD or have a disease flare. I haven't found personally that my IBD patients are more stressed than others. I think I've not found a causative relationship at all. Now this, as you can imagine, is a very difficult topic to study or prove, because in order to prove this, one would have to be able to measure. And as you can imagine, stress is a highly subjective topic. It is not like pulse, blood pressure, creatinine. You can't objectively measure, and hence it's very hard to prove. I would say the vast majority of medical and scientific experts don't believe that a causative relationship exists. In terms of the scientific evidence on the topic, there have been some weak studies that have suggested a causative role, but those are they've only found, at the most, they've been able to find a causation. So they've not been able to, they've only found an association, they've only found a weak association, not an actual causation. And those were very limited studies. It's really not been proven by any stretch at all. So how it's thought to work is that the emotional stress is thought to drive and sensitize the autonomic nervous response. It's similar to what happens in IBS in that there's two elements to this. There's firstly visceral hypersensitivity. The nerves in the GI tract start to sense brain signals as being painful. They should normally ignore and disregard brain signals and sense or regard them as being painful. The other element to this condition is what's called dysmotility, where the bowel contracts either too quickly, causing diarrhea, or too slowly, causing constipation. So essentially it's the so-called gut-brain pathways. It's been argued that if someone is experiencing psychological stress or poor mental health, they can go into what's called a fight or flight response, whereby they have sympathetic activation, parasympathetic inhibition. So the so-called butterflies in the stomach feeling. So So in terms of coming on to histological features, so there's a profound infiltration of the lamina propria with neutrophils, macrophages, and dendritic cells, and natural killer T cells. So it essentially involves all pathways of the immune response. This then drives high levels of tumor necrosis factor, interleukin B1, interferon gamma, as well as interleukin 23. So in UC, there's crypt abscess and crypt distortion, whereas we never see granulomas in UC. And frequently there's pseudo-polyp formation in UC, whereby there's it may look to be polyp, it's just basically swelling of the bowel wall. In UC, there can be small bowel involvement. What happens if they have pancolitis, the disease can spill into the small intestine where they have so-called backwash ileitis. That's usually quite mild. It's usually not severe disease. In terms of clinical features, UC patients most commonly have bloody diarrhea with mucus. They'll have low abdominal cramping. And unlike IBS, where opening the bowels tends to relieve the pain, here it actually gets worse after opening the bowels. So the key feature here is that they have anyone having IBS would usually would have diarrhea. They usually shouldn't have much blood. If they have hemorrhoids, if they're passing blood and mucus, it probably is IBD, not IBS. Now, because of the blood bringing it to attention of the treating doctor as well as the patient, UC is usually diagnosed fairly soon after presentation. Usually most people who have a UC will be diagnosed within a matter of months. It usually would not stretch beyond that. Whereas the Crohn's, I've frequently seen patients who have been diagnosed years afterward, because they can have subtle small bowel Crohn's disease. It may not be brought to attention for many, many years. And I've had several patients whereby they might have been diagnosed in, say, 2010, but they report in retrospect they probably had symptoms for 2 or 3 years before that. It just wasn't picked up. So remember, the pain will depend on the disease location. If they have distal disease, they might just have left lower quadrant pain, whereas with pancolitis, the pain will become more generalized. As a general rule, pediatric patients will have more severe disease. They're more likely to be pancolitic in their involvement. They're more likely to stand prostomy over time, and they're more likely to come to needing colectomy as well. Anyone having distension, guarding, rebound probably has toxemia of the colon. Those are all alarm features. So Crohn's, however, is a relatively much more subtle disease. Once again, the symptoms depend on the disease location, its extent, as well as the severity. They can have, if they have early chronic involvement, they can have what's called postprandial pain, where they feel pain after eating. What they then do is patients often psychologically associate eating with disease severity or disease triggers. They then start starving or fasting. That often contributes to the weight loss as a result. If they have gastroduodenal involvement, that's when they start to have nausea, vomiting, epigastric pain, or even dysphagia. If there's involvement, if the whole stomach is inflamed, they could potentially have delayed gastric emptying, and of that results in reduced caloric intake. If there's diffuse small intestinal disease, they typically have severe pain, diarrhea, and weight loss. They'll have features of malabsorption and malnutrition as a result. There's often secondary lactose intolerance because of damage to the small intestine. So in terms of examination, they'll typically have diffuse abdominal tenderness. They usually don't have clubbing. Now, conversely, it's quite a heterogeneous disease. If they had colonic Crohn's disease, it could quite easily mimic UC, whereby they'll have bloody diarrhea and mucus. Then they can have typically they'll have cramping pain relieved by defecation. They'll often have perineal disease with fissures and fistulas. Now, Crohn's is not a static disease. It does change and progress over time. At diagnosis, they'll have the inflammatory, relapsing, remitting, flaring disease that responds well to anti-inflammatory therapy. As time goes by, the disease changes over time. It becomes more of a fibrotic scarring disease. As they start to accumulate scar tissue in the bowel, the disease changes start to become, they get fibrostenotic disease, there's bowel blockage. and the conversely, they're then less likely to respond to anti-inflammatory therapy. They won't respond as well afterwards. So the prednisone wouldn't work as well at that point. I'll just to digress for a second. There's also a phenomenon known as what's called undifferentiated colitis. So that's where, so not everyone can be uniquely fit into the UC or Crohn's. Sometimes it's not very clear as to what they actually have. I should mention this is not a criticism, but pathologists virtually never ever declare for one side. They never tell you it's Crohn's UC. They just say features, or they just report they just report inflammation. They never actually diagnose. It's usually the colonoscopist who makes the diagnosis. With undifferentiated colitis, in a lot of instances, they later turn out to have Crohn's in most cases. There's also a phenomenon known as look, I won't go into it today, but there's a phenomenon known as microscopic colitis. That's where people have either lymphocytic or collagenous colitis. Now that's a phenomenon whereby the colon, they usually present with profuse watery diarrhea, going 10-15 times a day. It's very troublesome for them. They usually are diagnosed in colonoscopy, whereby the colonoscopy, the bowel looks macroscopically normal, but the biopsy shows inflammation. So they usually respond to synthetic steroids. But that's a relatively much milder disease. They don't usually have much in the way of morbidity, mortality. They don't ever progress to bowel cancer or fissures or any perforations. They usually do relatively much better. So in terms of fevers, it's typically low-grade chronic fevers. It's usually not a high fever unless they've had an infection or a serious complication. One would more expect to see weight loss in Crohn's and in UC. In children, they can have growth retardation or growth stunting, basically from malabsorption as well as from steroid use. And not surprisingly, they'll be chronically undernourished because of poor nutrient uptake and abdominal discomfort. They can develop a full-blown protein-losing enteropathy with intestinal losses. There's often high levels of cytokine. It can cause, in terms of children, it can cause delayed onset of puberty. It can also cause irregular menstrual periods. It can have quite profound effects. So coming on to the extraintestinal manifestation. So remember, it's not, although everyone thinks of it as a disease of the intestine, it's a systemic disease. In essence, it's not it's predominantly they should be thought of as systemic diseases that predominantly affect the intestine. They're not just GI tract. So the patients frequently have arthralgia and arthritis. I should mention they tend not to have destructive severe joint disease. So they virtually never have the joint destruction you might see in rheumatoid arthritis, for instance. That usually doesn't happen. Not uncommonly, they can precede intestinal manifestations whereby they can have joint pains before they start to have GI symptoms. This usually does correlate with disease activity. So whereby if the bowel is active, so is the joints, and conversely they respond. So if the intestinal inflammation is treated, they usually respond to that. There's two different disease patterns seen in this condition. There's either the peripheral form, which is usually poor, articular, typically the large joints of the lower limbs in terms of the knees, the ankles and the hips. It doesn't tend to involve the arms in terms of the wrists and elbows quite so much. The other form is what's called the the axial form, which is ankylosing spondylitis or sacroiliitis. So unlike ankylosing spondylitis, where they virtually all have HLA-B27, in this setting, HLA-B27 is only seen in about 50 to 80%. And ankylosing spondylitis the axial form is a bit different. This does not correlate with bowel syndrome, so they tend to run a separate and independent disease course. In terms of the mucocutaneous lesions of IBD, they can usually have oral mouth ulcers. They usually are not severe. They usually cause only mild to moderate discomfort. They do tend to parallel disease activity. One should treat the underlying disease. In terms of the cutaneous manifestations, there's two main categories. There's erythema nodosum as well as pyoderma gangrenosum. So erythema nodosum is more commonly seen in Crohn's. It usually occurs when the bowel is inflamed, so it does correlate with intestinal disease activity, and hence does respond to a treatment of the bowel condition. Pyoderma gangrenosum is usually seen in UC. It's relatively uncommon. That's where they have deep, severe necrosing ulceration of the skin, and that usually that also parallels active disease and does require usually local corticosteroids are required. So that's a slide of, so it doesn't come through very well. That's erythema nodosum. Those are the spots. These are the spots here and here. And that's pyoderma gangrenosum. So you can see the skin necrosis. So in terms of coming on to the ophthalmological complications, this can result from IBD itself or disease or complications of therapy. Typically they'll have, there's varying manifestations. There's episcleritis, they can have scleral erythema, conjunctival erythema, they can have photophobia that responds to steroid drops. An iritis is associated with HLA-B27. That once again behaves independently of the bowel disease. Remember, it's an association, it's not a cause and effect. It's not a direct cause and effect. They typically have eye pain, headaches and blurred vision. They respond fairly well to steroids. Hepatobiliary disease, typically they'll have what's called PSC or primary sclerosing cholangitis. That's whether there's fibrosing, inflammation and obliteration of the bile ducts. Usually seen in UC. This was a common exam question back in the day. You have a patient with stable known UC. He or she now has abnormal liver function tests. It's probably PSC until proven otherwise. So the reason we don't do screening, the reason screening is not performed for this condition is that early treatment does not change outcomes. So that reason is not usually worth screening for. So that reason I would not routinely check LFTs in UC patients for that reason. It can be either asymptomatic, it can be commonly diagnosed in the asymptomatic point, or they may have quite prominent pruritus. So typically they'll have rising ALP and GGT levels. Now the disease course here is not related to the underlying bowel disease, and even after having colectomy it can continue to progress. So typically they'll be P-ANCA positive. So the diagnosis is made usually on ERCP or MRCP or liver biopsy. They can also have concurrent or autoimmune hepatitis. So the treatment for this, they usually get ursofork, but that's only been shown to improve liver parameters. It doesn't have a substantial effect on disease outcome. So they can have renal disease with nephrolithosis due to uric acid deposition or oxalate calculi. They can have hypercalciuria from prolonged bed rest or corticosteroids. They can have secondary amyloid. Not uncommonly there's intravesical fistula, or even they can even have, rarely if there's an inflammatory mass from Crohn's, it can even obstruct the ureter, present with with obstructive renal failure. So bone abnormalities, this can occur from the disease itself, from IBD itself, osteopenia. As you can imagine, there'd be, because of malabsorption, poor calcium absorption, or steroids can do it as well. It's quite commonly seen in pediatric IBD. So this, not surprisingly, is more common in Crohn's than is in UC. So other condition to be aware of, of course, is avascular necrosis. It's a common but overlooked diagnosis. That was an exam question as well back in the day. Someone's on steroids, say for polymyalgia rheumatoid, suddenly has someone's hip pain. It's probably had avascular necrosis. So in terms of the diagnosis, one should exclude first enteric pathogens. Remember, infectious colitis can mimic IBD, and one could be fooled in thinking one does have IBD, and that can be quite a diagnostic trap to fall into. In that if they were to start to receive, if someone was mistakenly diagnosed as having IBD when they're in fact infectious colitis and started on immunosuppressants, it would only get worse after starting on immunosuppression. The treating doctor might be fooled into thinking that it's disease is not responding when in fact they're just they have something else entirely. So there's several pathogens that can mimic IBD in terms of Salmonella, Shigella, E. coli, and Entamoeba. So in terms of the diagnostic tests, I'd start off by doing a blood count looking for anemia. That can be multifactorial, they can be iron deficient, they can have B12 folate deficiency. I check white cell count as well as platelet count, check acute phase reactants. They'll frequently be iron deficient. I should mention iron tests can be difficult to interpret in this setting because they can have, remember the ferritin is an acute phase reactant. It can be falsely elevated. I would look at the serum iron and transferrin saturations. Those are lower. Even in the setting of a normal ferritin, I would regard that as being iron deficient and administer an iron infusion. I should mention these patients should really receive iron infusions. They tend not to respond to oral iron very well at all. So you can, even if they're having steaks, red meat 3-4 times a week, Having 2 iron tablets, that doesn't seem to work. It's just best to go for an infusion. They have hyperalbuminemia, reflecting the disease state and often malnutrition. There can be elevated liver enzymes. I check P-ANCA and ASCA. I do stool cultures looking for infection. And look, there's not done so commonly now, but in the pre-calprotectin days, we show often measure stool leukocytes. So someone having high leukocytes, they probably had, which means they had inflammation within the colon. So that was back in the day, it was a sensitive, but of course an entirely non-specific test for the presence of intestinal inflammation. Coming on to calprotectin, this is an antimicrobial protein. It's mainly synthesized by neutrophils. It's a sensitive marker to identify and monitor intestinal inflammation. It can be used in various disease settings. Now, it unfortunately does not identify etiology. I should stress that, because it can go up from multiple factors can push it up. Anything causing mucosal inflammation, whether it's acute gastrointestinal illness, if they had a big polyp, if they had diverticulitis, if they had previous radiotherapy, bowel cancer, anything can really put it up. But it is useful to differentiate IBD from IBS. I'll give you a clinical scenario. Let's suppose Mr. Joe Bloggs goes to see his GP. He tells, oh doctor, I've had diarrhea for a couple of years. I sometimes have a bit of bright blood there. I have some cramping pain. So then the dilemma is as to whether this patient has IBD or does he have IBS with hemorrhoids. So in this setting, calprotectin is quite a useful test to differentiate. If this patient had a normal calprotectin, there will be strong evidence that they did not have IBD, in fact have IBS. If conversely the calprotectin is up, that's probably suggesting the presence of IBD and hence the need to refer to a gastroenterologist. So it's quite useful in that setting. You can also use in other settings as well. So not infrequently, patients who have a known IBD come to see the gastroenterologist. They report that their disease is playing up in that they're now they're very bloated, they're very gassy, they're a bit constipated, they sometimes have diarrhea. So of course IBS affects 20 to 25% of the population. Not uncommonly they can have IBS. So in this setting, calprotectin is very useful to see to make sure that they're not actually having IBS instead. If they're having all these symptoms of a normal calprotectin, it probably is IBS, whereby if it's raised, they probably have IBD flare. Bearing in mind they don't always have to have diarrhea, they can also have constipation as well. What can happen is that one segment of the bowel becomes inflamed and narrows, it blocks passage, they can actually have paradoxical constipation. So it can be used to evaluate disease activity. It also helps predict disease recurrence. So if someone's on a biologic therapy and there's a question as to whether they're responding, the presence of a higher calprotectin suggests a lack of response. Conversely, a normal level suggests they're doing well. It can also be used to predict response to treatment. Now the normal range is 50 and below. I should mention, as with any other test in medicine, there's a very big grey zone. Very commonly in clinical practice, I have people calculating 65, 70, 80, even 90. Look, most of those don't have IBD, but it just shows that the point is that there is, as with any other test, a bell curve. So some people will naturally lie outside the bell curve. So there was a STRIDE-3 study that recommended anyone having known disease, once you use 150 as a cutoff, whereby you could accept, and the rationale why it's set at 150 instead of 50, is that even with the disease in remission, remember that they still can always have some low-grade disease activity, whereby as a result the calprotectin might not be 100, might be 100, 120, just reflects low-grade disease activity, which does not necessarily produce a clinical response, but it can be ignored. So this is the flowchart I'd use here. If I suspect someone has IBD based on history, clinical symptoms, I'd measure fecal calprotectin. It's in terms of the costing, Medicare will cover calprotectin 1C for someone known IBD. For someone who doesn't have IBD, it's about $90, but that is much cheaper than seeing a gastroenterologist or having a colonoscopy. So it's in fact a very good cost saving. If it's 15 below, then they really don't have inflammation. Then they're unlike of IBD. One should look at alternative causes. If it's 50 to 150, that's, as we discussed, the grey zone. One could evaluate for other causes. It would not be unreasonable for these patients to have a colonoscopy in that that would remove diagnostic doubt and allow a definite diagnosis to be made. You may pick up polyps or even lesions in the bowel. And the other advantage of doing a colonoscopy is that would then stop any further investigations. And after that, you wouldn't need any tests beyond that. 150 and above is probably reflects mucosal inflammation. Those patients should really proceed straight to having a colonoscopy. Now this is the flow chart for established IBD. 150 and below is usually the disease you'd think would be in remission. Then they probably do have underlying IBS, or alternatively they could have other causes, such as they might have celiac disease, they may have an infection. If it's 150 to 250, they probably have low-grade disease. Then I would just perhaps fine-tune the medication. If it's 250 and above, then they probably are having disease flare, then those patients should then be validated for change in treatment. So endoscopy in IBD plays a very crucial role in terms of diagnosing, managing as well as treating IBD. So one can do gastroscopy, sigmoidoscopy, as well as colonoscopy. There's also a role for capsule study to validate the deep small intestine, as well as chromoendoscopy. So colonoscopy so ideally patients should always have terminal ileal intubation. There's a couple of reasons for that. So a novice or inexperienced colonoscopist might, while performing colonoscopy, be fooled into thinking that he or she has reached the cecum when in fact they've not. So there's a parts of the transverse colon might be mistaken for the cecum. So that by the trouble with having an incomplete procedure, you might miss a lesion in the proximal colon. Bearing in mind the last 20 years has been a shift towards right-sided bowel cancer. So for that reason, terminal ileal intubation is desirable, and let's just see for Crohn's. So this confirms the diagnosis beyond all doubt. And also in terms of someone who has active disease, it also helps confirm mucosal healing, so hence it helps clarify that they're responding to treatment. Anyone having mucosal healing has had sustained remission, they'll have reduced hospitalization, and then they're usually less likely to require surgery. And with colonoscopy, one can take biopsies of inflamed as well as not inflamed mucosa. One can differentiate whether it's UC or Crohn's. You can exclude other causes in terms of ischemic colitis, diverticulitis, or infectious colitis. I should mention it is not supposed to be performed in severe colitis. Reason being is, especially in severe UC, the bowels inflamed, it can become paper thin. There's a very high risk of causing perforation. The danger of doing that is if one were to perforate, God forbid, an inflamed colon, it's very hard for a surgeon to stitch the ends together. It's very hard to achieve anastomosis. And plus, it doesn't really even give very much information. For that reason, I would often perform a sigmoidoscopy in such patients. So you just generally look inside and go as needed. It's better not to charge blindly forward. If someone had toxic megacolon with the bowels dilated to 6 centimeters and more, I would not perform a procedure at all in those settings. So in terms of colonoscopic features, there are some pitfalls I should mention here. So UC patients can occasionally have rectal sparing. One common scenario is if they've received treatment with, say, enemas, then the rectum may be spared, which is of course a mirage. They can also have, and UC patients can also have sometimes a patch of inflammation in the cecum, or so-called periappendicitis, and that can be, so the colonoscopist could think that they have Crohn's and in fact they have UC. So aphthous ulcers, cobblestone, are usually seen in Crohn's, and whereas if there's isolated terminal ileal involvement by itself, that usually would be Crohn's. It can never be UC. But then there's also the pitfall whereby you could have potentially a severe pancolonic Crohn's disease with ileitis. It's hard to tell as to whether it's UC or Crohn's. The feature I'd use there is I'd look for granulomas, number one, and number two, in UC it should be more severe distally and less severe proximally, whereas with Crohn's that would not be seen in Crohn's. Those are the key features I'd use. I think that was a MCQ back in the day as well. So these are the gradings I'd use in terms of erythema, grading from 1 to 3. So 0 is basically there's no inflammation or there's mild erythema, going on to severe bleeding in terms of the so-called Mayo score. That's the score we use to qualify people for biologic therapy. Ulcerations, there's grading of ulcers as to whether it's in terms of the size, the score, and how much of the bowel is involved, and how narrow the bowel is. So a routine gastroscopy is not routinely done in Crohn's. So the indications would be if someone had a pain or weight loss, nausea, vomiting, or if someone has unclassified or indeterminate IBD, any upper intestinal would diagnose Crohn's, and it cannot possibly be UC. So I should mention upper GI disease is frequently seen in pediatric patients rather than adults. So capsule study is useful. Let's just look at the small intestine, looking for erythema or small bowel strictures. So it is not supposed to be on patients with known strictures. Remember that the capsule can block the bowel. And if someone has known small bowel Crohn's, they usually have what's called a patency capsule, whereby they swallow a capsule and to see if there's any blockage, and only proceed if it's negative. And if there is a blockage, that diagnoses the stricture. So in terms of bowel cancer surveillance, this is a important topic of interest. So anyone having long-standing IBD, even if the disease is in remission, remember they've had many, many years of increased cell turnover and which increases the mutagenic potential because of a high cell turnover. They then inherit a risk of colitis. Anyone having more the more the bowel that's involved, the higher the risk. Anyone having at least 1/3 of the colon involved would be at high risk. So the mortality has dropped in IBD because there's now increasing awareness of this. So what this is, so typically it's someone who's had colitis for many, many years. There might be, disease may be dormant, they may not even worry about it anymore, but the trouble is these patients are then at the highest risk of having colitis as compared to those who have had disease for less periods of time. So ideally they should have chronic biopsies every 10 centimeters to detect dysplasia. It can be quite tricky because someone has active disease, it can be quite hard to tell a pre-cancerous or cancerous lesion from a disease flare. So remember, bowel cancer arises from dysplasia, so the idea is to detect them early. There's different grades of dysplasia. There's negative, you can either be negative for dysplasia, be low grade or high grade. You know, when I was in medical school, and they used to have a classification of medium dysplasia. That's been since done away with. Now, unfortunately, with dysplasia, there's a fairly high inter-observer variability in that what one pathologist may cause low grade, another pathologist may cause high grade. So the incidence reaches almost 20% after 30 years. It starts to rise around about 7 to 8 years after diagnosis. It just goes up progressively after. So for that reason, anyone having disease over that period of time should be then considered for surveillance, even if they're in remission. In terms of risk factors, having someone have the disease for being diagnosed early in life, someone having had longer disease duration, someone with severe intestinal inflammation, or remember someone having stricturing disease, the bowels then been quite inflamed, and then they probably had developed precancerous changes. Someone having pseudopolyps or a shortened colon. Remember, the colon shortened has probably been quite scarred, and there's probably been quite a lot of basically genetic change in terms of malignant transformation. Anyone having a family history of bowel cancer is at high risk, and PSC is a strong risk factor as well. So endoscopic surveillance is widely recommended for early detection and surveillance. It leads to improved survival. Anyone having PSC should be surveilled annually, otherwise I do it every 1 to 2 years. I've started about 7 to 8 years afterwards, and I do it yearly, 1 to 2 yearly after that. So there's what's called a high definition or narrowband colonoscopy, which allows better detection of it allows the colonoscopist to better differentiate cancerous or pre-cancerous lesions. So if there's visible dysplastic lesions in parts of the bowel that are not involved by the colitis, those patients should ideally undergo polypectomy. If the lesions aren't able to be lifted, it's probably malignant. If it's ulcerated, that's a sign of malignancy. If endoscopic resection is unfeasible, if it's quite extensive, it's probably best to have a colectomy. Unfortunately, patients can have what's called endoscopically invisible dysplasia, whereby dysplasia shows up in biopsies, but it's not visible to the naked eye. In that setting, they probably should have colectomy because they're quite likely to have synchronous bowel cancers. Now, it's a bit controversial whether patients with low-grade dysplasia should have colectomy or not. As you can imagine, this is a topic in medicine which is not easily studied. It's very hard to enroll such patients in clinical trials. And there's one study that was done which found that out of patients who have low-grade dysplasia, only 5% progressed over a 3-year period. So there is argument for prolonged surveillance and monitoring in such patients rather than going down the path of colectomy. multifocal high-grade dysplasia is a very high-risk factor. Those patients should definitely have colectomy because they can progress even in the interval between colonoscopies, they can progress to full-blown bowel cancer. Pouchitis, that's where, remember, patients have the bowel removed, just have a residual pouch. That's quite limited disease. Those patients tend not to be high risk of bowel cancer because they only have very little bowel left. Pouchitis is mainly bacterial. They usually are not a very high risk. So in such patients, you can probably even do it 3 yearly in those patients. That's what I used to look at as a boy. And ate too many naans. So obesity I was just talking about the effect of obesity in IBD. So obesity does increase IBD disease. Actually, remember the concept is as follows: visceral fat or fat around the waist as compared to fat around the buttocks and thighs is a very metabolically active. So many years scientists mistakenly thought that the fat just sat there and did nothing. In fact, it is very metabolically active and in fact causes quite profound inflammation and damage. So it basically works. It is carcinogenic. It drives fatty liver. So people can have liver cirrhosis as a result. It's thought to be very pro-inflammatory. It's been found that patients who are obese will have more disease activity. They'll have longer course of hospitalization. They're less likely to get into remission. They're more likely to have treatment failure. They don't respond to TNF therapy as well. What it is, the fat is thought to act as like a TNF sink. It just sucks up all the biologic, and hence they need more treatment. As a correlation, obese patients are more likely to be depressed and have poor mental health. That could potentially arguably drive the immune response. That could potentially, one could argue, make the disease worse. It could promote treatment non-compliance. They're more likely to have extraintestinal manifestations. They're more likely to end up having biologic therapy. So coming on to treatment, there's pharmacotherapy, there's immunosolicit, which involves immunosolicits or 5-ASA, corticosteroids, immunomodulators, and biologics. So I'll discuss them all in turn. So in terms of the goals, one wants to induce as well as maintain remission. One wants to prevent and treat complications, and ideas to have mucosal healing. The reason that term is thrown about so often is that's what correlates with good response. So anyone who has mucosal healing is in remission. Those patients are the ones who are asymptomatic. They have no bleeding, no diarrhea, no pain. They're fully healed. So this is associated with very reduced rates of recurrence, hospitalization, surgery, and they have a very good long-term prognosis as a result. So in terms of immunosolicits, these have been around since the 1930s. This includes sulfasalazine and 5-ASA. So in the early 90s, that's my reference point. So I keep going back to that again and again. So basically 30 years ago, that was the only treatment for IBD. All the people had was immunosolicits and steroids. And back in those days, in fact, up until about 2005, if you had IBD, it's only a matter of when rather than if you came to surgery. So I think that those days, something like 60 to 70% of people with IBD end up going to surgery. Those having Crohn's would often have multiple surgeries. They lose multiple parts of the small bowel. Nowadays, there's been a huge paradigm shift that's not really done anymore. So 5-ASA block by blocking the metabolism of arachidonic acid, which converts to prostaglandin and leukotriene metabolites. This also tends to block free oxygen radicals. It has profound effects on white blood cells as well as cytokines. They tend to induce the so-called regulatory T cells. Remember, what's happening is there's an unrestrained immune response. There's normally what's called the suppressor T cells, which are meant to switch off the immune response. In IBD, as in other autoimmune diseases, they're just switched on. This tends to induce them to switch back on. Hence, it dials the immune system back off again. So they are superior to placebo in terms of maintaining remission. There was some suggestion that they're not as effective in Crohn's, but that's not true, that they can be quite safely used long term. They're usually very well tolerated by most people. Look, very rarely someone might have some mild nausea, vomiting. I rarely, if ever, have to stop them. Most people can continue them long term. This allows a reduction in steroid use, but they can occasionally cause nephrotoxicity that's usually mediated by an allergic response. So corticosteroids have been used since the 1950s. They effectively reduce remission. They're far stronger and more effective than 5-ASA. They work very quickly. They do not maintain remission. So they will switch this, they will not stop it from coming back. So hence they should not be used for this purpose. So there's numerous side effects. In younger people, there's typically cosmetic side effects that can be quite distressing in young women in terms of acne, pimples, and the moon face. In older patients, in the geriatric population, there's muscle wasting, osteoporosis, and increased falls risk. So, of course, the older patients, a 75-year-old man is not going to come and complain, oh, doctor, I've got a moon face, whereas obviously young person will be much more, understandably, much more upset by that. So it's different for different populations. There's now increasing interest in using what's called second-generation corticosteroids, which is bugenicide and cortimand. They are Medicare rebated for patients with chronic intestinal inflammation. They're obtained under streamlined authority. And how they work is they have a very high first-pass into metabolism. They have a very high affinity for corticosteroid receptors. There's restricted delivery to the ileum as well as the colon, and this way they work very effectively. One would start at 9 milligrams a day, then gradually taper them down. Eventually you can have, I've had patients with IBD who just have 3 times a week. So one can taper down quite well. There's also then coming on to immunomodulators. By this I'm meaning is azathioprine or Imuran, CITS-MP as well as CITS-thioguanine. Now they work by blocking T lymphocyte proliferation and activation. How it works is T lymphocytes infiltrate into the inflammatory side of the mucosa. They drive cytokine production. These are quite favorable and effective in both UC and Crohn's. They reduce hospitalization. They also reduce rates of surgery. They have a steroid-sparing effect. They also maintain remission. They unfortunately do cause bone marrow suppression as well as liver injury. And there's also issues of gastrointestinal intolerance. So before starting these agents, I'd check full blood count and also thiopurine methyltransferase activity, or so-called TPMT activity. So 10% of the population has low metabolizers of this, which means they'll have toxicity at low doses. Around 0.3% of the population is absent. They don't metabolize at all, don't metabolize the drug at all. Those patients at high risk of having toxicity, so I'd measure a baseline, then do full blood count LFTs every couple of months. I do the first one at baseline at 1 month, and then as time goes by, I just do it less and less often. I should mention I put liver injury there because they can be hepatotoxic, and that can often require dose reduction. They often can also be, the Imuran is an organic drug, admittedly can cause nausea, vomiting. Imuran is one of the worst offenders. Imuran is well known to cause nausea, vomiting quite frequently. Methotrexate is used in Crohn's, does not work in UC, so it works by basically blocking DNA synthesis. It also tends to downregulate inflammatory cytokines. So anti-TNF therapy, the tumor necrosis factor plays a very critical role in inflammation, apoptosis, and driving the immune response. Essentially, if there's overexpression of TNF, that drives inflammation as well as autoimmune disease. By this I'm referring to infliximab and adalimumab, or so-called Humira and Remicade. There's now numerous biologics out as well. So they are very effective in terms of reducing hospitalization and need for colectomy. They also, and they especially work well to close fistulas as well. Remember, the fistulas are driven by tumor necrosis factor. However, they are not a be-all end-all. 40% of patients don't respond at all, and about 30% of patients have initial response followed by a loss of response. So this can be overcome by increasing dose levels or giving infusions more often. There's now increasing interest in giving Imuran to such patients. What happens is, remember, they're humanized monoclonal antibodies. So by giving Imuran, even if the Imuran wasn't effective for the disease to begin with, one can start these agents to prevent them forming antibody formation down the track. So I would measure trough level as well as anti-drug antibodies. So then there's also interest in using anti-IL-12 and IL-23 therapy. Now IL-12 and 23 are pro-inflammatory cytokines in intestinal inflammation. They have a very key role in the pathophysiological response. They both induce as well as drive intestinal inflammation. This is typically a ustekinumab or Stelara. It's again a humanized antibody that blocks IL-12 and IL-23. This then blocks these cytokines from triggering off T cells and natural killer cells. This blocks intestinal inflammation. They can be used for both Crohn's as well as UC. So integrin, there's also anti-integrin therapy, which, integrin, remember, is a cell surface glycoprotein receptor. This mediates leukocytes. What this does. This basically drives or guides leukocytes into intestinal mucosa. They bind tissue cell adhesion molecules. It promotes cell retention. It also but they not only promote cell retention, they also drive the inflammatory response. They play a very key role in IBD pathogenesis. So by giving anti-integrin therapy, we can block the effect of integrin on leukocytes as well as anti-epithelial CAM molecules. So as a result, leukocytes no longer interact with intestinal mucosa. This is used as vedolizumab or so-called Entyvio. So Entyvio is again a recombinant humanized monoclonal antibody. The reason it's humanized is to prevent the body from forming blocking antibodies to it. So they're quite, however, it has a relatively limited effect. It only blocks leukocyte migration. It doesn't directly switch off the inflammatory response. The other agent is etrolizumab. There's also increasing interest now in JAK inhibitors, which is an oral agent. This is used for UC. It's basically a small molecule JAK inhibitor which blocks the JAK signaling pathways. This very strongly drives the inflammatory immune response. There's also SP1 receptor modulator as an agonist. This is a lipid mediator that plays a regulatory role in terms of activating receptors. So one can use ozanimod or etrasimod. So this blocks leukocytes from reaching inflammatory sites. So there's different approaches in Australia. We have what's called a step-up approach, whereby in order to have access to biologic therapy, a gastroenterologist must certify that a patient has failed to respond to 3 months of therapy with both prednisone at 40 milligrams a day for at least 6 weeks, as well as at least 3 months of either Imuran or SITS-MP. However, the PBS is quite compassionate and very reasonable in its approach. If someone's had drug toxicity, then they'll accept that and not force you to use them. So they're quite, I found them to be very reasonable in that regard. But the point is, they don't want us to use biologics from the word go. The idea is that biologics take up more than 65% of the IBD budget. So I think I saw figures, the IBD costs Australia about $5 billion a year, of which the majority is taken up by the cost of biologic drugs. It's not actually the cost of hospitalization. It's really these drugs are chewing up everything. So the idea is to, of course, limit and ration their usage is the idea. So whereas in Europe they have what's called a top-down approach, whereby if the clinician suspects someone has severe disease and is not likely to respond to conventional therapy, they can use biologics then from the outset. So the idea is as follows. If someone has IBD, usually the disease is more responsive to therapy early on when it's in the inflammatory state, whereas over time they start to become relatively resistant to therapy. The idea is to treat them with more effective disease control early on using biologics from the word go. They can also be used as a so-called bridge to therapy. The idea is to prevent escalation need for surgery. So we're aiming to basically alter the natural disease history as a result. However, there's increased risk from using these drugs, and I should mention they're not PBS approved or even funded in Australia. So that approach. It's really only done in Europe, it's not done anywhere else so far. So in terms of prescribing agents, I'd check first tuberculosis and hepatitis B. So look, I should mention tuberculosis is almost unheard of in a native-born Australian. If you had someone with the name of John Smith who's, say, of European background, the chance, and he'd never left Australia, the chance of having TB is just infinitesimally low. If you had someone from, say, a high-incidence country like, say, Nepal, who'd migrated in the last few years, he or she could well have the disease. So I'd perform chest X-ray as well as quantiferon gold. If someone's on a biologic agent, they probably should avoid traveling to a TB endemic area. I'd check hepatitis B and C serology. I'd also immunize against hepatitis B. One can do annual flu VATs as well as 5-yearly pneumovats. That's to prevent infections, and of course there's an increased risk of having abnormal pap smears from HPV, so they should have probably yearly pap smears. Surgery is still an important treatment for IBD patients for those who are not responding. However, I must say the rates have dramatically plunged as compared to previously. So in terms of the absolute indication of surgery, there's uncontrolled bleeding, there's perforation, either confirmed or suspected carcinogenesis, or the presence of toxic megacolon. The relative indications of surgery are severe disease with failed therapy, if there's toxic megacolon, or there's either fistulas or perianal disease. So I'll put this slide just to discuss the commonly overlooked issues of IBD care. So as you can imagine, it causes, I'm sure you've experienced with your patients, they will have difficulty working, they'll have to take time off work, they will have to lose income. There's often a key issue is access to a toilet. So it's, and people who work outdoors, or tradesmen, or taxi drivers, Uber drivers, it's virtually impossible to have access to a toilet. An office worker could still have a toilet nearby, but even for them, if they're on the phone, it can be problematic to be dashing to the toilet. It can be hard for them to catch. If they're having to commute to work by public transport, it can be hard to make the commute if it's a long drive. They often will have to have their desk or chair seated near a toilet cubicle, and they often will have to report they have to interrupt and get up during meetings to go to the toilet. It of course disrupts people's studies and it disturbs education. It adversely affects the quality of life. So anemia is usually multifactorial. As mentioned earlier, it doesn't respond to oral iron. They should all get IV iron. It causes damaging effects to psychological health in terms of anxiety, stress, and depression. They can have sexual dysfunction. It's a common cause for infertility or difficulty conceiving. They can often develop secondary GI conditions, and if they're smokers usually have quite poor outcomes. So in summary, IBD is an umbrella term for patients who have conditions causing swelling, inflammation of the GI tract. Typically they'll present with abdominal pain, diarrhea, and rectal bleeding. It ranges from mild to moderate to severe in intensity. There's broad ranges of treatment, and disease complications include cancer. So if I would finish up with a case study.